We're going to get started here.
Is that on?
Doesn't seem that way, does it? There we are. We're going to get started here.
Oh, I mean, I wonder if you, sometimes you have to step back and use it.
Hello?
Yeah.
Sorry, stand in front of you. This event, I'm Mary Moriarty, I'm the Hennepin County Attorney. This event is very near and dear to my heart because I was once, and this was decades ago, a community member who didn't know what to do when I got a phone call that my stepsister was sitting in the middle of LaSalle Avenue with a bottle of alcohol. She struggled with mental health and substance use, and I had no idea what to do. But I happened to be clerking for a judge, and so I was able to talk to him about what resources were out there and what I could do to help her. And without that, I would have been lost. And I've had that experience over and over when people in the community have loved ones who are really, really struggling with various issues. And I know from a county perspective, because I've worked in the county for many, many decades, that the county and the city do have resources, but a lot of people don't know they exist. They don't know that they exist, and they don't know how to access them. So this is a really important event to get the word out there about some of the amazing, wonderful resources that are available to community through the county and the city. So I'm just going to introduce the people on our panel here and where they're from, and then they're going to take it from here. Also, we're going to have a QR code where you can put that in your phone and give us feedback about this event. So if you could do that, that would be much appreciated. We also still have food, so if you're hungry, please help yourself. Okay, so we've got Kaliat, Julma, Kafaya. I'm sorry, that's what happens when I'm not wearing my glasses. From COPE, and she's going to tell us all about COPE. We have Kayla, Rennie, and Assad here. Kayla's here, Assad is here. They are from the Family Response and Stabilization Services. That's one of the best programs that a lot of people don't know about. I actually became familiar with it this year, and it's really exciting and really important resource for people in the community. We also have Mary Reed, who is a social worker from 1800 Chicago. Supervisor, wonderful. So when I was Chief Public Defender years ago, I was co-chair of the Behavioral Health Committee, and we were part of designing and getting 1800 Chicago up and going. And so I am very excited about that program as well, but it is also a program that a lot of people in community don't know about. So I'm excited to hear about that. We will have Sherry Hansen with us in about 20 minutes. She's from the Canopy Roots. And we have Reed Raymond, our very own Hennepin County Attorney's Office, Reed Raymond, who will be presenting on what our Adult Services Division, which deals with commitments and generally trying to help people figure out what to do when they are struggling or a loved one is struggling. So I'm going to hand it over to them, and they're going to give their presentation. So please give them a big hand.
Can you hear me?
Yeah. Okay. Yeah. There we go.
Can you hear in the back?
Okay. Yes.
Good?
Yes.
Okay. So my name is Kafaya Jomack. I'm a licensed marriage and family therapist and a licensed drug and alcohol counselor. I'm a supervisor with Hennepin County COPE. I've been with COPE for 8 years. I think COPE has existed since about 2006, a little bit before that in a different capacity, but roughly 2006. I think maybe the easiest way for me to explain what our service is to describe what could happen from start to finish. So we are 24/7, 365. We serve all ages. and serve anyone as long as they're within the bounds of Hennepin County. All of our services are triggered by a phone call, usually either a call from the client themselves or a concerned community member or a professional that they're working with. But essentially, we get the phone call, they describe the situation, we try to gather some basic information and then do some of our own research based on information we might have. And then within an hour of that phone call, we're trying to get out to see that person. We don't have a facility where people can come and see us, we're coming to see you. Really the only places we don't go is if someone's already inpatient at the hospital or if they're in the county jail, because they have their own kind of ways of handling mental health crises. So yeah, and so we say our clients define the crisis, so clients can call for really any reason. It's usually a mental health related concern, but it could be anything from, I had a really rough day at work today, I just really need some support, to I just lost a loved one, I'm actively suicidal, I'm struggling with, some of the thoughts in my head, I might be hearing voices that aren't mine, things like that. And for families, it might be my kid's not going to school for the third day in a row and I don't know how to handle it, I don't know what to do at this point. So we'll try to gather some of the basic information and then head out and talk to the person, talk to the family, and see how we can help. Based on the conversation we have with the individual or with the family, there's a number of things that can happen with that assessment. We call them assessments. We're maybe writing a short-term intervention plan where, we make a plan with that person about what next steps should be, what they need to do, what some self-care things are that they can do. And for a lot of people, that might be all that they need. We'll do a 24-hour follow-up call to check in and see if there's any other ways we can support. And yeah, that might be we might never see them again, or we'll see them in another 3-4 months when they're kind of in that rough spot again. For a lot of people, we might do a safety plan if there are concerns around thoughts about harming themselves, harming others. A part of that safety plan for us is offering some means restriction options. So means restriction is, there's a study that says most people who act on a self-injurious behavior or on suicide do it at an impulse. So if you remove the impulse, next time they're less likely to act on that impulse. So we provide gun locks if folks identify having a firearm and thinking about that as a means to hurting themselves or others. And we offer lock boxes that can fit medications if, someone talks about overdose, sharps, ligatures, things like that. Really anything that can fit within the box. We'll have that conversation with the person about what it's for, why we're doing this, and kind of include them in that plan. That's another possible outcome. Third possible outcome is a referral to our stabilization services. So we have another team of folks that will work with that person ongoing. So essentially, if we feel like we can't manage the situation in this one visit, we'll refer them to STABE. They can work with that person for up to 8 weeks, and they'll do some brief therapy and some case management, trying to just help them get connected to longer term services. With that, we have an HSR and a CMA, so a human service rep and a case management assistant. They help with navigating benefits, so medical assistance, food stamps, really whatever else the individual might need support with and is maybe struggling with getting access to. We have a partnership with the Mental Health Center over on Lake Street in Hiawatha, and they have some reserved appointment slots for us that we can plug people into, so we can get people in pretty quickly, for sometimes within a day, for psychiatry appointments, medication prescriptions, things like that, for either immediate need or ongoing services. And then I think the fourth option, if none of those work out, if we feel that we can't walk away from this situation without some serious concern that the individual could hurt themselves or hurt somebody else, then we're talking about going to the hospital. Best case scenario, we can have that conversation with the individual and get some buy-in and easily navigate getting them there. Worst case scenario, we're writing what's called a transportation hold, which essentially says, we feel like you need to go, even though you might not feel like you need to go. And all that really does is get them to the hospital and gets them assessed at the hospital. The hospital will do their own assessment and decide whether or not admission is needed, whether or not a 72-hour hold is appropriate. Yeah, what else? So that's the majority of what COPE does. We have a new service that we kicked off over a year ago. So everything I described thus far is COPE attending to the individual in crisis. We now attend to communities in crisis. And it kicked off really when there was the shooting at South Education Center and North Minneapolis High School. We were there weekly, sometimes daily, for about a 3-month period after the incident, as the students were coming back into school, just supporting the staff, supporting the students. And I think one of the kind of catalyst moments for us creating this team was just one of our supervisors sat with the football team at North, the football team and the coaches, and facilitated a healing circle. And for a lot of them, that was their first time talking about that incident and being in a space where they felt safe enough and comfortable enough talking about what had happened and how it impacted them and what they felt. So we wanted to have a team dedicated to doing that work, to be able to support a community of people that is struggling through a traumatic event. So we've done a lot of other things since, and yeah, I think to put it simply, I think that captures everything that we do.
Thank you, Kafayat.
Yeah.
Turn that mic.
Can you hear me?
Yeah.
I talk really loud, so I probably don't need the mic, but
I can move down.
Over here.
can you all hear me in the back?
Nice job.
Let's try to see. I can get to myself.
Hello everybody, can you guys hear me?
Yes.
Good evening, my name is Asad Dahir. I'm a program manager in behavioral health, supporting the work of this wonderful program called FRSS, along with our Children's Mental Health Initiative grant that we get from SAMHSA. I'm their project director. Before I get into the detail of the program itself, I would like to give you a little bit of the purpose. So, who wants to go back to 2021? Raise your hand, right? So this is in 2021, Hennepin County initiated community engagement. Comprehensive community engagement through our teams, our partners like Hennepin County Children's Mental Health Collaborative, just to understand what are some pain points, what are some gaps that exist that communities or families were struggling with. And the data we got became pivotal in standing up family response and stabilization services. So without getting you deeper into the data, let me just give you 3 key points. 90% of families we talked to at the time said in a moment of urgency related to my child, I'm not sure where I need to go, where to turn. We knew where families were turning up in large number, or hospitals, kids that were sleeping in ambulance bays, families who were not sure where to access support and services. The second data point was 84% of families said, I'm tired of you guys giving me a phone number and a flyer. When I need help, and now I would like to have some service navigation. Somebody who can walk me through the services that are available rather than just giving me a phone number and then 4 hours later I'm at this starting point. The third data point was 65% of families said, I would like to work with somebody who understands what it feels to be my own child growing up in my community, culturally specific supports and services. We didn't have to look far because SAMHSA or the federal government had a framework that they put out 1983, almost 40 some years ago, called the System of Care work or framework. And that really captures the essence of the program we have. Because when you look at who defines your crisis, you should be able to define your crisis because all these factors go into culture has an impact on how people perceive crisis, whether it is from you or how you read it. Duration, sometimes they peak, sometimes it's a plateau. Response, so the way people respond to you is also culturally informed. Settings, things that you could do as a child at home, at school are different. So all of these really get into defining what a crisis is, and no one should define your crisis. This is the basis of family response and stabilization services. Because the idea is, if families tell us what they need, and we support them and provide interventions that are timely, appropriate, the right time, the right service, the right dose, we don't focus more on the visible. And the visible is the symptoms, the behavior. When those needs are unmet, they manifest in a behavior, and then we say, let's deal with, stabilize the behavior. So can we go further than behavior and support those needs? Those are the invisible. So with family response and stabilization services, I love this book. It encapsulates everything we're trying to do with family response. Beneath every behavior, there is a feeling, and beneath each feeling is a need. And when we focus or when we meet the need, rather than focus on the behavior, we begin to deal with the cause and not just the symptoms, right? So then how does family response work? System of care. What is this framework? Is it not just a philosophy? People just throw it out when they want you to say, what are we doing? Something different. And how are we doing it is really important. If we can go to the next slide, please. Next. So system of care, this framework, calls for culturally responsive, so that the people you serve and the people who serve them, really there is that congruence, and people feel like, again, the 65% of families who said, we would like to work with somebody who knows what it feels to be my own child. Integrated services, so that families don't really feel they have to swim from one island to another, because people are getting flyers and phone numbers that are really supportive at the moment, but are not really delivering the work we want to see. Data informed. The pivotal point of starting the service was the data we got from communities and families that said, we really need help, because if you're not there, we're either going to the hospital, sitting at an ER setting for 7+ hours only to be told to go home, or we're calling law enforcement. And law enforcement are going out and seeing a child who is struggling with behavioral needs, and then they don't know what to do. They either transported that child to a hospital setting again. And trauma is really prevalent and pervasive in our community. So if you have a trauma-focused lens, you can support families and community engagement, not just at the starting point. Everything we do with FRSS, from the people who deliver the service to how we ensure the continuous quality improvement. Kayla will talk more about that, so I don't want to steal her. Kayla, please. Is that my last one? Yes.
Yes, it is. All right. So a little bit about family response and stabilization services. We really are working with all families, birth to 18, but we don't work just with that child. We're working with the whole family. We really are concentrated on making the family itself stable. We're offering de-escalation and that immediate in that immediate time. So we get to wherever you are within Hennepin County within an hour. We're doing an assessment. It's a very basic assessment, and then we're also connecting folks to services. And the great thing about our services is right now we have up to 72 hours of connection. So we oftentimes will go and connect with the family, and they're gonna be like, can you come back tomorrow morning, because I know it's gonna be difficult to get my youth on the bus. Can you come and help practice these skills you just taught me? And then we go out the next morning as well. And then our 8-week stabilization program is an optional support for folks who are interested in that that more consistent, longer term care, and then we're also hooking them up with additional resources and having more opportunity to kind of practice those skills that may be beneficial to them. A little bit about our team. As we've mentioned, we're a very diverse, multicultural team. We're offering services in English, Malay, Spanish. We're meeting families and communities where they're at. We have program manager, we have mental health professionals, we have practitioners, we have the family responders, we have team leads, the community care coordinator, and a parent peer support specialist. And what we know about everyone is everybody really specializes and has the same kind of framework and passion that we're not just a clinical service. We really are trying to be at that intersection of community, culture, and clinical, so we can best heal families and support families in that least restrictive setting. Again, this is a little bit about how we approach, this is the youth and family concern, and we're, again, in that intersection, in that space I talk about the community. We're in the community, we're seeing how we can support crime reduction efforts, we're getting folks involved in extracurricular activities, we're connecting with all the community centers, letting folks know where we're at, and in that cultural space, we know that clinical work is not the only way that individuals heal and the only way that folks want to access services. Some people would prefer a more traditional way of being supported and working through some of their concerns, and we're complementing the services clinically with that cultural connection as well. And of course, we do offer those more of those traditional mental health services, diagnostic assessments, therapeutic interventions, and skill-based work as well. So a little bit about who we serve. So which this is probably one of the slides that I'm most proud about is when we met the communities and when we hired our staff and when we were doing the work, we were very intentional because the current average demographic of a crisis caller calling a crisis line is a white female aged 12 to 16. Our average demographic is a Black or African American age 14 male. And the data that I pulled just for 2024 also says our highest number of callbacks is also for folks in this demographic, which says they trust us to come in their home, they trust us to do the work, and they felt respected and supported while we were in their home, and they felt the work that we did was crucial enough and beneficial enough that they called us back and welcomed us back into the home. So this is probably, like I said, the most significant data that I think we've been able to show with the efforts of the work that we did, and it's really about strengthening and building those cultural and community connections. And again, I just think why our model works is because the family is truly defining the crisis. Anything that there's not an acuity level that needs to be met. Whatever they need, we're going to go there and support them. Again, we have those multiple modalities of healing that we talked about, and we're truly trying to be youth-centered, again, and have that client and youth choice and voice heard. And again, it's a little bit different than how the current crisis models are working. Then we'll pass it back to Assad.
So when we started the program in 2021, I think there were only 3 responders, correct me if I'm wrong.
Correct.
So we wanted to keep this really small. We were partnering with hospitals because that's where families were, sitting for this long hours only to be told to go home, and there weren't any very responsive to their needs at the moment. When you look at this number, 1,600 calls, and families define what the crisis or needs or escalation or urgency is. There is no reject or eject policy. If you call, it is a priority for you. We do a short assessment over the phone. Majority of that, just to assess if there is a safety concern, individuals that shouldn't be there, animals, guns. If those are not, we like to go into the community, in the home, or a safe setting in the community and sit down and have that face-to-face interaction with families so that we're not doing assessment over the phone that's cumbersome. In 2024, we've had 800 calls, we doubled, and how many staff do we have right now across the 3 agencies? I believe that there are 20. 32 individuals that are delivering. The service is 24/7. We also work closely with COPE as a partner, and in 2023, December 2023, we rerouted the child crisis line from COPE to FRSS. We still coordinated with COPE on some of the families when they call, ensuring that no matter who you call, COPE or FRSS, every family should get a responsive support for their needs. The calls we get, the majority, in 2023, the highest calls were coming from a hospital. We didn't want to stay there for too long because we were being reactive. That's why we needed to be at that moment, but we didn't want to stay far too long. We partner with schools, we partner with community, and the largest number of calls we got in 2024 were from parents and caregivers who felt there is something I have concern about or a need, and I'm going to call this number so that I can receive that support. The majority of calls we get, familial conflict, aggression, oppositional behavior. How do you, in a clinical sense, right? Familial conflict could be very broad term because every family is unique, every family has different strength, every family has different level of support. If they're telling us there is a need, we go out and meet those needs. Next, please. All right. Can you hear me now? All right, good. And the program has the 2 phases. The first one is immediate within an hour up to 72 hours. The second one is really the 8-week stabilization support. We have teams that are Somali speaking, Spanish speaking. We have a team in Changing that's African American staffed. We want to make sure the communities that call really get somebody who represents them and their unique identity or cultural heritage. So this is not once and done. This is the way I see family response and stabilization services. And if you want to look a little more about this model, in other places they're known as mobile response and stabilization services, MRSS. But we wanted to make it unique to our own Hennepin County, and there is no better way to center that than put families first. So family response and stabilization service. When we get calls or when we have families in stabilization, it is sometimes sequencing for long-term support. We know 8 weeks seems a long time, but some of the families who are coming with really complex needs. But it is, at one quote I like to offer is a family who said, having FRSS stabilization support felt like somebody took me to the ocean and showed me what the ocean looks like before finding yourself submerged and somebody's trying to tell you now you're in the ocean. Because the way she said it, it was like every time I had a need or something, it felt therapy was what was offered. I don't know what that is. I don't know what diagnostic assessment entails, but having somebody who speaks your language, who comes from your culture, sit down with you and explain to you all those in details and offer you support, that was critical for that family. And having the 8-week stabilization support, there are times when families finish. The problem we're getting right now is families finish and they say, oh yeah, that was 8 weeks, right? Yeah. So can we make it 16 weeks? And we go, I don't know if we can because of the model, right? We want to make sure. Then they go, okay, that's fine. 2 days later, they might call and say, I wanna work with Kayla, can you give me another 8 weeks? Now we can say no, right? Because if you call, you get again the service. So that's some ways now we're trying to make sure families get that support and it sequences for long-term services and supports. Some of the, I think we were getting to the last one. We were getting an hour, right, for presentation? I feel like we're just, no, I'm sorry, it was 20 minutes, I feel like we're just. So the partners we have are schools, hospitals, foster care. The only time we go outside of Hennepin County lines is when a youth is a Hennepin County resident, now placed outside of Hennepin County. I know the first time when I looked at the data and I saw Chisago, I was like, we're going to Chicago now? And then she's like, no, it's Chisago. I was like, okay. Because I thought we were all over now. So 911 embedded social workers, child protection, youth connection center, parent organizations. Those are the critical partners we're building to ensure that every Hennepin County resident has access to this 24/7 service. This is a little bit of a sample. I mean, if we could bring all of the data, it would be here for a long time. We would be here for a while. So, Kayla, if you
Yeah, so we, of course, we send out surveys and we elicit feedback from all of the folks that we're serving, because in order to improve and to be representative of the community, we need their feedback. And these are just some of the feedbacks that we've recently received. Family response was fantastic and gave us the support needed to de-escalate and problem solve to prevent an ED visit. I can't find words to thank and appreciate family response's support and help. I appreciate the ability to have someone come into my house in a quick time frame to help with our situation. I like the follow-up and action plan that was put in place and additional services that we could start right away. And lastly, family response's help was exactly what we needed to help us navigate a difficult day. I can't say enough about how much he helped to defuse our situation. He was really able to connect with our whole family, including our 17-year-old son. And I think that really speaks to, again, the work that we're doing with the whole family. We know that in order for a youth to be successful in their home, that the whole family needs to be able to be supported. And so we're making sure that we're not just focusing on the parent or the adult or the caregiver, just the kids. We're really bringing everyone together to support the family in order to keep them in their homes and in the community. Thank you all. This is the first time we've done this presentation so quickly. We had to really summarize here.
All right.
Thank you.
Guys.
Maybe privately. I'll give you an answer.
Okay. I stole your seat.
Oh, you're okay.
You want to move down?
Sure.
Okay, all right.
Oh, yeah.
It's helpful if you stand back a little bit, because when you come up here, that's when the mic stops. Okay. I didn't know that, yeah.
Yeah, we're great.
Hello, everybody, good evening. Can you hear me okay?
Yeah.
My name is Mary Reed, I'm a supervisor at Hennepin County. Ms. Naima Ali is my program manager that's sitting back there, and she came with me today. And we are excited to tell you about the Behavioral Health Center that we love. It is very unique in its own way, and I'll give more into that in a little bit. So the Behavioral Health Center, we have traffic that come from a variety of sources, including but not limited to, as you see, the walk-in, early diversion. First, they can't hear me anymore? No. What about now? Okay, I'm gonna try to hold it like this. So, but we have traffic that comes from a variety of sources, including but not limited to, as it states, the walk-in, early diversion, first responders, law enforcement, mobile crisis teams, outreach teams. 1800 in Chicago is an alternative to the hospital and jails. So we act as a stabilization center for Hennepin County.
I think I can do that line.
If you slide over to the other side, we're gonna keep it there for me. On the other side, it says that we can help you to connect with on-site services, withdrawal management, mental health crisis, the DART team, which is diversion and recovery team, the vocational services program, which we call VSP, is going in and out.
It's going in
I
and
can hear
out.
it.
Yeah.
Do you want me to try that one? And I can also project my voice too if you like. I can try that.
Yeah, try that right now.
Okay. So I'm gonna try to project my voice, so please forgive me if it sounds like I'm yelling at you. Okay? Project Child and Health Insurance Navigation, we no longer have the SSI SSDI team there, but uniquely we're placed right across the street from the Social Security office. So we're able to provide those services and walk a resident right across the street, or either we can do some things with them online and make phone calls. The thing that's amazing about us, which when this was first developed, we were only open Monday through Friday, but what's very unique is now we're open 7 days a week. So Monday through Sunday from 9 a.m. to 9 p.m. And people can come in. Okay, as you see, we just wanted to give you just a little view of it. It's a county-owned 3-story building, 102,000 round square feet and 1.65 acre site. Yes, please, thank you. This is just the front of the building. This is 1800 in Chicago. The next 5 slides is just gonna be pictures, so I'm gonna go really fast. Thank you so much. This is the front entrance that you see as soon as you walk up to 1800 in Chicago. This is our back entrance. This is our after hours entrance. So this is on Columbus Avenue. So what happens is that if you notice this little, excuse me, this right here, and it has the buzzer and the different things that they press. But what that entails is that there's for withdrawal management, which I'll talk about that in a little bit, reentry crisis as well as us. So after 5 p.m., all of our doors lock, and that's just for safety and security. So then a person will come and they'll buzz in, and we'll have someone right in that area, which is our case management aides. They'll be right there to assist them. So in this building, we have 3 floors. We have withdrawal management, which is at the top. We have the second floor, which is crisis. Then our first floor is our walk-in center. And that north wing over there is where our dark programs are, our VSPs, and our Project Child. I'll get more into that later on. And then this is what it looks like. The walk-in center is a beautiful place to come. We're known for this little bubble wall, which I think I have a slide about that later on, but you'll see why it's so unique. So when you enter in off of Chicago Avenue, when you walk into this section, this is where our case management aides are, and they'll be ready to greet our residents and get them roomed into an exam room. So pretty much this slide already tells you, that there are many services, many supports. We are there to work together and get them connected. When you enter the center, we are big on treating you with respect and dignity. Our services are offered without judgment, without coercion. We don't do any of that. You are in control. Your choice matters, your voice matters. So we have values up here, but we're going to call them guiding principles. So, yeah, that's okay. So then there is one that's off of here that we did not include, but it's team-based care. But we have harm reduction, which you can see what the slide says, which is nothing about us without us. We can support people in recovery based on their definition and through relationships. I apologize, it feels like I'm hobbling, I'm sorry. And then person-centered thinking. What does the resident want for their life and for their health? We have short-term stabilization, next best thing, one thing at a time. Integrated care. What does the resident want for improved stabilization, functioning, and quality of life? Trauma-informed care. Remember that everyone is carrying more than we possibly could know, so we proceed with care. As you see there, we didn't say proceed with caution, we proceed with care. Health equity, who benefits and burdens, as well as team-based care, which everything that we do it as team-based. Our care coordinators, team-based. CMAs, team-based. Supervisors, team-based. Everything is team-based. Again, I have already explained this part to you, but we focus on mental health, substance use, social services. No appointment is needed. You come in, you don't have to call, you just come right on in, and we're there to greet you with a smile. Okay. All right. Is this better?
Yes.
Okay, all right. Thank you. Yes, please. So pretty much what I had already explained was that you will show up there, you will get signed in with our office support specialist, and then a case management assistant, which is a CMA, will come and they will greet you and they will bring the residents, because we call them residents, we don't call them clients, we don't call them patients, we call them residents, that they'll bring the residents into an exam room. So who works there? CMAs, case management aides, care coordinators, peer support specialists, a medical team, on-site supervisors, our program manager, and that's pretty much what we have, as well as one more. We have a psych team where we have psych nurses there, as well as we have a psychiatrist there that are from the mental health center, I think it's at 2215 East Lake Street, but they come to ours on Mondays, Wednesdays, and Fridays. They're on site with us. So we can get you connected to all sorts of services, just like it says, you know, everything that I have already mentioned, we can move on. Yeah. And then here we also are big on substance use and recovery. We try to meet people where they are. We believe in harm reduction and overdose prevention, education, the Syringe Service Program, medication assisted treatment, and admission to withdrawal management and substance use disorder treatment coordination. Yeah, we can go to the next one. So here we have naloxone kits right on site in case somebody needs them to help to prevent someone from, or to try to reduce the risk of someone overdose and die. So we have peer support specialists. These are people with lived experiences, whether it's mental health, chemical health, criminal justice. They are there to help walk us alongside of our residents to just, you know, show them that they can make it through too, just like they did. No judgment, no coercion. Whatever that you need, we're there, we have it. The social services, which someone talked about earlier, we have a kiosk in the lobby. We have HSR staff there quite often, if not every day. We have a human services rep there. They can help you with those things that were just listed. Yep. You can move on. We also have medical services there. We have nurses there. They can help you with those different things here. Monday through Thursday from 9 to 4:30 p.m. They are not there with us at night. And then I think that we have extended to weekends too. Is that correct?
Yes, we do have nurses at our center on the weekends.
Thank you. This is what the treatment room looks like. If you are being examined, you know, by the doctor, the nurses. That is one of the treatment rooms. You go. This right here is the assessment room. This is where the care coordinators and the CMAs take you inside of there. You can be comfortable. We have those chairs where people can just lay back and just relax, you know, where they can just feel safe and just, you know, take a load off. You know, we provide snacks, we provide coffee, we provide soups. We just try to meet them where they're at. Sometimes a person just needs to just know that they're safe and that they can come inside of there and there's no judgment. This is the famous bubble wall. If you take a look, it makes all types of colors. Bubbles are going crazy everywhere. Everybody, some people just come and literally sit in them chairs and rock and just look. They be like, why you don't have fish in there? I'm like, well, we don't have fish. Oh, we have bubbles in cups. So I come take a load off and relax. You see sometimes people are working in this space, just kind of sitting back looking. Some people are charging their cell phones because we have tables where you can charge your cell phones, you know. It's a really, really nice, cozy place. You'll have to come and check it out if you have not been there. Now we're going to talk about the second floor very briefly. This is the mental health crisis residence, which is known as reentry crisis. They are open 24/7. There are up to 16 openings each day, you know, based off of the bed availability. And these beds are for people that are in a mental health crisis. We often collaborate and send people upstairs to the second floor if they would like to go. This is unique in its sense because a person can come in and out of there all day if they need to. They can come in and out. They can go smoke their cigarettes, you know, whatever they vape, you know, whatever that they do, you know, they can come in and out of there. Mm-hmm. Now we're talking about the third floor. The third floor is a little bit unique. You're not coming in and out of the third floor. You're going to relinquish your clothes, everything on your persons, and they're going to give you some scrubs and things. They're going to feed you, you know, give you a place, you know, where you can kind of, you know, detox and do what you need to do. That does not mean that they're locked in there, that they can't leave, because again, you have your own free will. If you say my stay here is over with, then your stay here is over with. It was very nice meeting you, and they send you on your way, but you can always come back. We have plenty of beds up there. There's a female side, there's a male side, there's single rooms, there's shared rooms. Again, I just kind of covered this one so we can go past that. Where the only thing that was unique about that was that they can help you to also get a comprehensive assessment done, and that they can help you to get connected to treatment if that's what you desire. If that's not what you desire, then again, whatever that you desire. The DART team, the DART team is a voluntary interdisciplinary case management team for Hennepin County adults living with substance use disorder. And basically, they have all of this right up in that north wing that you heard me speak about earlier. Go ahead, 'cause I'm trying to beat the clock. We got Project Child, which is very unique. Project Child works with individuals who are pregnant and living with a substance use disorder. Project Child works with the pregnant person and their family supports person and birthing team to keep the family together so that the mommy can have a good healthy pregnancy, and to try to it's like a where they come alongside of them to try to make it so that they don't end up in child protection. So and they understand that some moms that they use, so they try to help them to get to where they have to be so that they can have their needs with them. And then the VSP is all about jobs, resumes, just to try to get your job ready. That's also up on that north wing. We have a whole computer lab, and staff is ready there to assist you. Benefits, health, cash, health insurance, all of that again is part of our HSR team. Again, we have the kiosk there, we can help you with that. Same thing, we have admission navigators. Now, they come on Tuesdays from 1 to 4, where they can help people to get set up with insurance. On Thursdays, they're there from 9 to 4. Everything with us, again, for that is first come, first serve. The resident advisory group, that's very dear to my heart. We do this every other month. It's normally the 4th Friday of the month. It's from 5 to 7. 5 to 6 right now. So what we do, and they're like, yep, you can just keep this one slide up for me. What we do there is that we call it dinner and a conversation. We just want to work with you. We just want to talk to you. So we have a few questions. What we provide them is a meal. Last time we had, Red Robins, We do like nice little meals, and then we also compensate them with a $20 gift card, a Visa gift card, because we appreciate their time. And they're just able to come and answer some questions, because we want to know, how are we doing? Are we meeting the community needs? Are we addressing your concerns? Is it a good idea, that we're open 9 to 9? Is it a good idea that we're open 7 days a week? Typically, the feedback is phenomenal, and people are like, yes, we're glad that you're here. And then the other slides, I won't need them. I just wanted to kind of give you all just a little glimpse into the Behavioral Health Center. There's one other thing that we have, which is a part of a pilot program. It's called Competency Attainment. And we generally get those referrals from the courts. We have navigators, and we have one peer support specialist that is leading that. And the work that they do is that the navigators will assess a person in court. It's all voluntary, so it's not mandated, even though you hear me saying courts. They'll all come to the center. We have a facilitator guide and a workbook that we try to work with them with to get them court ready. Some part of it, he even talks about what to expect in court. What I'm saying? Where does the judge sit? Where does the county attorney sit? It's like a really good support for them. However, they can come as many times as they like. We would love for them to come and stay with us for a while. But sometimes they're just one and done. They just want to come, get the information, and then they go on. But that's a pilot program that we are a part of. And that's it. Thank you all so much.
Yes.
Thanks. All right. Thank you so much, sir. I appreciate you. I'm still on here. So, me on track.
So hello, it's strange to speak to a microphone, but my name is Sherry Hansen. I am the program supervisor at Canopy Roots. We are an organization that provides culturally responsive care for mental health crises in the city of Minneapolis. It's right here. So Canopy is composed of two sister organizations. Canopy Mental Health and Consulting is a therapy practice. We primarily serve, or we seek to serve everyone, but we focus on being competent and prepared for serving diverse people of all kinds, people from all types of backgrounds. We want them to be able to come and get help and get appropriate care that is right for them and their cultural orientation. So at some point, Canopy Roots is the sister organization, and this is actually the part that operates the Minneapolis VCR. So our approach for both organizations, okay, we actually focus very highly on hiring not just people who look like the folks that we serve, but really are interested in serving people who are different than them. We want to have a diverse workforce so individuals can come in and share their knowledge and ensure that we are all prepared to serve the community. So we want to have responders that speak various different languages. We want to have responders from various different races. Along with that, go back. Oh, sorry. I'll go back. I'll come back. This one. There you go. So this is important. So identification of natural and cultural strengths. We don't come to the situation, our responders do not come to people with an idea that we understand what they need. We seek to get to know you and partner with you and help you find solutions that work for you, your environment, your culture, your situation. And right there, affirming dignity above all else, right? That's everything. Historically, as we know, individuals struggling with mental health have not always been treated with dignity by social systems. So, our goal is to affirm dignity above all else, and as we know, that can almost be a radical act. But it's what we do every day. So, our responders utilize the practices of cultural responsiveness and cultural humility. It just simply means that we don't go in with our biases leading you. We want to, again, partner with you, see what you need, and take our biases and ideas out of the equation. We're learners, we're participators, and we follow your lead. So actively, right along with that, actively decentering or resisting centering white American culture as default. This simply means we are committed to understanding that there are many different values and ways of living that are valid, and we will meet you there. So we can consider community, historical, and political context. All I need to say is this, right? Minneapolis, before George Floyd, was a very different place, right? Now Minneapolis feels different. And that historical and political context means everything now. It changes the way that we work with our community. So we might know these numbers, but this is why we exist. So 1 in 20 adults experience serious mental illness each year. 1 in 4 police encounters, fatal police encounters, involve an individual with a serious mental illness. Like, that number is still shocking. And I think I wrote this slide. It's still shocking to this day. So we can do anything to bring that number down, to change that. We're going to do it. That's why we exist. So 1 in 4 adults lack a regular place to access healthcare, which just means that their needs are going to kind of spill over into the community and contribute to the need for emergency care. So that's what we help address as well. So We're the behavioral health crisis response for the city of Minneapolis. Our purpose is to provide person-centered, culturally responsive crisis services 24/7. It didn't used to be that way. We started out with less, but now we've got to providing full 24/7, 365. So of course, our goals are to decriminalize mental illness, avoid involuntary hospitalization, but also appropriately activate the hospital when it's necessary. Provide an alternative response to law enforcement for 911 calls. That doesn't mean, that just means simply that we are going to the calls that are more appropriate for us. And these mental health calls, police didn't need them anyway, right? We want to handle those calls so we can come up with safe resolutions to crisis that relates to mental health in the community. So our responders are unarmed in every way. Just show up in I think she's got on jeans and our t-shirt right there, and come to help you where you are. So all of our responders are trained mental health practitioners per the statutes, and we also provide them extensive training at the beginning when they're first hired, and we continually train them weekly, actually, to just make sure that they are competent, they have the most recent knowledge, and that they're also pushing themselves to provide unbiased, appropriate care. So we are integrated into 911, right? There are lots of crisis programs, but what makes us unique is that we're integrated into 911. So someone calls 911 and it sounds like there's a behavioral health crisis involved. Now, dispatch will place BCR on the call. Also, if you as the community call and say, I would like BCR, they check it out, but oftentimes you will get BCR sent to you if dispatch deems it appropriate. So, that being said, we are independent. We're integrated, but we are independent. We set our own standards that are based off of mental health, not necessarily what other first responder organizations are doing. We're within, but we are separate in that we are focused on mental health and we have a different goal. Well, we probably all have the same goal, but we do it differently. We address mental health in a culturally competent way. Free and voluntary. You're not going to receive a bill, right? We do not bill any organization or any insurance. We want to make sure that when you call us, when you get our assistance, we're not sticking you with something on the other end, right? We want this to benefit you. We don't want to make it harder for you. And we have the ability to do that at this moment in time. So we'll glaze kind of over this, but this is just a little timeline for us. City of Minneapolis started before George Floyd started studying what a program like this could look like. They did a request for proposal, and at that time it was just Canopy Mental Health. We had just started it, and we of course bid for that and got the contract, so we've been providing that since 2021. So these are our vans. They're a mix between nondescript, but also we want you to know that we are the BCR, right? We don't want to be too obvious, but we want you to know that that's us coming. So as you see, they're accessible, wheelchair accessible, so even if someone is in a wheelchair, we can certainly transport to help resolve that mental health crisis. We don't always do assessments in the van, we try to do it outside of the van, but if it's necessary, if it's very cold, there is space in the vans for assessment and interventions. No lights or sirens, right? We want to be, that puts us in a position where the response time might be a little longer, but it also sets us as different than MPD or EMS, right? We get the calls and we still are very interested in ensuring that we get there quickly. Our responders are completely committed to that, but we just don't have the sirens to aid us. So this is who's eligible, or these are the calls that dispatch will put us on, okay? So it needs to be a mental health crisis. There doesn't need to be a weapon involved in the situation. Many people have weapons in their home, and oftentimes they'll just tell dispatch that. And if that's a non-issue, they will send PCR. But if it's in the crisis situation or escalated the crisis situation, we will not be placed on that call. So no known physical violence has or is occurring. Although I will say, sometimes if there was physical violence and the person is more calm, PCR might be activated to support. No known medical emergency, that's for EMS. EMS might sometimes activate us, but we do not take those primarily. Now, this again says drug and alcohol are not escalating the situation. However, we actually, as we know, mental health and substance use go hand in hand. So, we often can't avoid ending up in situations where we're supporting individuals who are using or currently high or needing support with maintaining sobriety. So, we will end up be sent to those calls, but if the only issue is that the person is high, we are not usually put on those calls. If that makes sense. So police and PD may request PCR through dispatch, but the incidents must still meet the above criteria. Same with if you, the community members, call and ask for PCR, dispatch still decides. So, our interventions. Once PCR is activated by dispatch, we'll come out in our van. There will be 2 responders. We always work in pairs. Sometimes you might actually see me or another supervisor or one of our other leaders shadowing responders, and that happens pretty often, so you might see me out there. But we're gonna move in a trauma-informed way. For us, what that means is we are going to assume that those we are serving have experienced traumatic things that give us the opportunity to meet them where they are and be careful about how we treat them, right? We're not interested in re-traumatizing anyone. We also understand that a lot of people have trauma related to their experiences with healthcare or people who are called by 911, right? And so we're gonna really act as if individuals need that extra care and support even before we know, right? Everything's gonna be done in a trauma-informed way. So crisis de-escalation, I would say that this is our main strength. Oftentimes when there's a mental health crisis and people are dealing with intense symptoms, if someone is hearing voices, that responder is not gonna be able to stop that. But they might be able to use their de-escalation skills to get the person more calm, feel more safe, so that they can think more rationally to come up with a plan, okay? Or if the person is unable to do that at that time, the responders will partner with family, neighbors even, anyone who's around that is willing and wanting to support that person struggling with their mental health, PCR will work with. I would also say that with crisis de-escalation, a lot of that is going to be done by providing you emotional support. I mean, the amount of venting that goes on, we love it. We're here for it, right? We are here to listen to you. And if that de-escalates the situation, and it often does, we're happy about that. So we want to meet you where you are emotionally, allow you to talk about how you feel, and then hopefully move on to some problem solving if we can. Psychoeducation. So oftentimes families may or may not know what is fully going on with their family member who is struggling with their mental health. So they may know well, they're speaking very fast. That's my tongue. They're speaking very fast. Maybe they might not be saying things that make sense. So the family member is not sure what's going on, they call us. And we might be able to give them an idea of what perhaps diagnosis that person might be experiencing. Again, we're not there to diagnose anyone, but we're going to just give information for and to the family so that they can get support for their loved one. So we're going to educate about those mental health conditions if the family is interested. Biggest thing we do, risk assessments, right? Along with de-escalation, we often provide sort of assessment to make sure that someone is safe, meaning if someone is experiencing a suicidal crisis, okay, we're gonna assess their risk, and then we're gonna make decisions related to their support based off of their level of risk, okay? So if a person is actively suicidal at that point, we're going to maybe start thinking hospital or other safe places like crisis stabilization, right? That might be able to help this individual. Speaking of that, I've seen a lot of the faces up here before because we refer and connect recipients to many organizations in the community as often as we can, and love to have that partnership so we're all working together to support people in the community. Skills training as well. Sometimes we do grounding techniques, sometimes we just sit with a person, talk with them about any old thing that's not mental health, and oftentimes that ends up de-escalating as well. We want to treat you like a human, and I tell you what, when you treat people like humans, you feel more human, and oftentimes it makes a difference in the immediate crisis. So that is all I have for the moment. Thank you all for your time.
Sarah, can I sit? Thanks. Hey, Sarah.
Here?
Sarah,
Yeah.
okay if I sit?
I think so. We'll just make
Okay.
sure the mic works.
Do we have those handouts too?
Yep, they're at the front.
Okay.
I'll sit right here.
Okay, good evening, everyone. Can you hear me all right? Everyone hear me back there? I don't know if this is working or not. My name is Reed Raymond. I'm an assistant Hennepin County attorney. I'd like to start off by extending my hand to you with a heartfelt handshake and say thank you for attending this evening and listening to all these folks that are dealing directly with crises in the community. I think that all of our families are experiencing difficulty. In fact, I don't know any family that can say they don't have some sort of mental health problem somewhere in their family. And I know I'm that way myself in our family. We're dealing with it. And so I wanted to, before I go much farther, I wanted to thank Sarah for organizing, and County Attorney Mary Moriarty. This is really a fantastic program that we have here this evening. And I wanted to tell you that I like this, I like you. Where I am in our community on the south side, we have a meeting like this in our Native American community. And it's just like this. We have food. Only thing is, before we start, we always have a prayer before we start. But we have food, and then afterwards we have a meeting, and we deal with serious issues like this. So this is where I like to be, right here with you. And I'm very happy to be here. And just so you know, I'm an enrolled member of the Rosewood Sioux Tribe of South Dakota, and I'm an Army veteran. And I've been active in the Native American community and the community, our community, since the 1970s. I'm a former president of the Little Earth of United Tribes. That's probably the one you know the most, but I was active with a lot of other groups. And I've had a lot of contact with the North Side community over the years. And we've had our community, the Native American community, has had a lot of support from the North Side community. So I appreciate that. And so in our office, the county attorney's office, we aren't dealing on the front lines like these folks are. We're dealing with court. And these days, we don't even go into the courtroom anymore. We're on Zoom. Most of our hearings, almost all of our hearings are on Zoom. And so that's been a big change that, the pandemic brought that about. So what I wanted to talk to you about tonight is our community response. We have a community response in our office. We take calls and we work with citizens when they call in. And families, and then also it can be providers or law enforcement, all different kinds of people call us. Attorneys, even the judicial officers may contact us sometimes. And we respond by trying to help as much as we possibly can. So, can you go to the next slide, please?
This one.
Yes. So, the civil commitment process is a fishbowl. There's no reason why anyone would know anything about it unless you had contact with it. And so, we have the same judicial officers, we have the same defense attorneys, we have the same county attorneys that work in that system. And so what I'd like to start off with is telling you just basically what a civil commitment is. And so it's an order for treatment that helps people that are mentally ill, chemically dependent, or developmentally disabled. An initial commitment lasts for 6 months, and almost every one of them is started by a hospital. And we do about 1,500 of them a year. And nearly every one of them is started by a hospital. And in the old days, the state hospital used to be where the people went when they were committed. But now there's no space there anymore. So all the people that are in a mental health crisis that are going to have a civil commitment petition, they're all dealt with in a community hospital. And then they are committed to a community hospital too. They're also committed to the Commissioner of Human Services. But the second commitment site is a community hospital. And that community hospital, if they get the order, they provide the treatment and they discharge the patient. That patient, upon discharge, will get a discharge plan, and they call it a provisional discharge, which is essentially the outline of a treatment plan, and that patient will get a case manager. So I don't want to see anyone committed, but some people really need it because they just can't help themselves. A lot of these people, they're in the crisis, they're not competent. But when they get some help, they regain their competency and they can agree to do the right thing to help themselves. A lot of the people we have don't have too much family support or community support. Some of them have none, but we all are trying to help our family members that are in crises. How many of you out there, raise your hand if you've had a family member that's been in crisis? I'm one of them, and we're still helping our family members that are having difficulty. So having a case manager is important. I know we're a little short of time, so maybe the next slide. So the basics of the commitment process are the person is transported to the hospital. There's a 72-hour hold placed on them. Usually there's a health officer or a peace officer hold that is the vehicle for transporting them. They get to the hospital, then the hospital has to decide whether or not they're going to place a mental health hold on them. If they do that, then they have to decide right away whether they're going to file a commitment petition. That requires a medical professional to write a statement that says the commitment petition is necessary. If they do that, then that is sent over with a write-up. It's kind of like a probable cause statement in a criminal case. It's just basic facts to support the reason why the person needs commitment. That statement and the examiner's statement are sent to pre-petition screening, and that all has to happen within that 72 hours, and that's exclusive of holidays and weekdays. So like if someone goes in on Friday Saturday and Sunday don't count. So, but it all has to happen. Commitment, the pre-petition treatment team then does the investigation, makes a recommendation on whether a commitment is needed. It's sent to our office, and we have to decide then whether to file a petition. And we almost always file one if screening supports it. And sometimes we file them anyway if there's circumstances that we think warrant the petition being filed. And then once the petition is filed, there's an initial hearing, hold hearing, and a meeting with a court psychologist, and that happens within 3 working days of when the petition is filed. And then there's a final hearing, if necessary, if there's no settlement, no resolution, and that's 3 working days later. That's kind of the basics of the civil commitment process. Who out there knew anything about this? Has some familiarity with it? Well, our folks in our office. Okay, we can have the next slide. Okay, so one of the problems that exists in the community is that the person in crisis is not getting to the hospital for one reason or another. You know, the example that was put forward when we first started doing this work is the person that's in the basement that won't come out, that's experiencing severe mental health problems. And the family doesn't want to cause a problem with them, but they're not getting anywhere. That person remains in the basement, is maybe hearing voices, or is using drugs extensively, and they're just staying there. So what happens there? So maybe COPE went out and didn't recommend a hold, or maybe BCR was there and they didn't think that the police should be brought in for a peace officer hold to take them to the hospital. So that's just one example. It can happen a lot of different ways, but we get calls from people in the community asking, well, what can we do? And so what we want to do is to help those people develop information that can be shared with first responders like COPE, like the police, like BCR, in your organization. FRSS, that can provide them the information they need to know so they know that the transport to the hospital is necessary. Because really we can't do the type of intervention the person needs if they're in crises without getting into the hospital. That's what needs to happen. So when you call in, say you call in and you have a relative that's in crises, but you're not getting the support you need to get them to the hospital, or they've been taken to the hospital and the professionals there have said, no, we're not going to put a 72-hour hold on them. We're not going to keep them at the hospital. We work with you to develop the type of information that is needed so that the hospital and the first responders can see that this person really needs the help they need. So that's kind of the essence of our work. You know, that's what we want to do. And so when that happens, a lot of different things can happen. You know, the person can go to the hospital and agree to get help, or they can go to the hospital and stay there for a while, and then a petition is started and we can do a settlement with them. They don't necessarily have to get a full commitment. Our goal is to make sure that they get the help they need. So as you have seen and heard, COPE and FRSS will go out if there's no serious threats of aggression or violence, and I think the same is true for BCR. If the other efforts don't work, you can call the pre-petition screening line, and they'll talk to you, and you can also call our office. We can't give legal advice, but what we do is we talk to you generally about how the process works. And so just like I am now, because people don't know. I mean, they really don't know how things work. It's very important that this information about the crises about the person in crisis is put together. The information about their history, their diagnoses, any threats of harm to themselves or others, failure to provide necessary food, clothing, and shelter. And in chemical dependency situations also, there's also a lot of times there's a medical component too. Like they're not taking care of their diabetes or their hypertension. I think we can go to the next slide. Okay, these are the things that we want to facilitate: earlier intervention, educating the community about how to get help for a person in crises. We want to be connected to community members and support them, bringing our system partners together to support the person in crises, reconnecting a person in crisis with services they need, and hopefully they'll voluntarily accept it and get the treatment they need. Eventually, if not, then that they would be brought to the hospital. And then, if necessary, there would be a commitment petition. So that's what we want to do. And I just want to say that from the first time I met Mary Moriarty, I knew that we were going to get support with this work. Not just because she had the stepsister with the problem, but just her whole demeanor about it. So she's been very supportive. Usually we've had to organize these presentations on our own. Now we're getting support from the county attorney to come out in the community and present. And some of us have been doing it for several years now. I really appreciate you. Thank you so much for listening. And I do want to thank my coworkers over there, my manager, Julie Hillel, and my supervisor, Charlotte DeJulio, for being here too. And I hope that we can have some questions before, I don't know if we got time. I'm trying to rush through to get questions.
Now, we probably don't have time, but I do want to say that, as you can tell when you've been listening, each of these presenters have much more to say about their work. And what's really exciting about this, for those of you who were here at the beginning, and I was talking about the fact that decades ago, I got a call that my stepsister needed help. A lot of these resources weren't available. And what's more exciting about it is hearing about the culturally specific, reaching where you are, the system isn't going to tell you what you need, is huge, absolutely huge. So we are a big supporter of all of you. I want to thank you for your time, for being here. Thank you for your work. It's so important to the community. And thank all of you for coming. Take some food, fill out, there's the QR code there. You can snap a shot of it and give us your ideas about what you thought about this. And I know there's information back there from organizations as well, and you can reach out. I'm sure they have websites with information on it to find out more about it and talk to people in the community too. Because these are amazing resources, but a lot of people, as they said, just don't know about them. So spread the word. And thank you everybody for being here, and let's give everybody a round of applause.